Welcome, everyone, to Navigating DRG Challenges, Strategies for Success in Documentation and Appeals. This webinar is presented by Vanessa Youmans, COO of Yes HIM Consulting. My name is Mari Selly, and I am the Director of Business Strategy and Client Services with Yes. For today's webinar, you are in mute mode. If you have any questions, please post them in the Q&A section on this webinar. We will be monitoring the Q&A section throughout the webinar and will answer any questions you may have. The chat feature is disabled. We've sent an email this morning with a link to download these webinar slides. There is also a link to the slides posted in the Q&A section shortly. After this webinar, we will talk about how you can access your CEU certificate of completion. Before we begin, I wanted to share a little bit about Yes. Yes HIM Consulting, also known as Yes, is a premier medical coding, auditing, and coding education company with recognized and HIM coding credentialed employees, serving health systems and physician groups nationwide for over 17 years. We provide expertise in health information management, billing optimization, and the merger between technology solutions and medical coding quality requirements. We partner with health systems in providing auditing, coding, and coding education, as well as consulting, coder mentoring, and denials remediation programs. So if you're interested in partnering with our team, please contact us at info@yes-himconsulting.com. You will receive an email today with a recording of this webinar and our contact information as well. So thank you again for your time, and I will share a little bit more about our presenter, Vanessa Youmans. Vanessa Youmans is the Chief Operating Officer at Yes HIM Consulting. Ms. Youmans holds a Bachelor of Science in Mathematics from St. John's University and a master's degree from NYU. As COO, Vanessa oversees multiple critical areas, including inpatient, outpatient, and professional fee coding, as well as auditing services. Her credentials include a Registered Health Information Administrator, RHIA, a CCS. She's also a CPC. And furthermore, Vanessa served as the Secretary of GAHIMA, the Gulf Coast Health Information Management Association, for 2019 to 2020, and as a committee chair for coding at FAHIMA for 2020 to 2022. Vanessa, take it away.
Thank you so much, Mari. And thank you all. I just want to take a second to thank you all for taking some time today to talk with me about DRGs and denials. And during our webinar today, we're going to do a little bit of an introduction, and then we'll talk about some common DRG downgrade triggers. We'll talk about building strong DRG support and really mastering those DRG appeals. So after today, you're going to have an entire toolbox of knowledge to be able to not only discuss DRG downgrades, why the payers are denying it, but you can also discuss how you can go about appealing those if needed. So just a little introduction. I get asked all the time by our clients or just people that we see at conventions or at networking events. People ask me all the time, Vanessa, is it just me or are payers denying more? And you may be thinking the same thing to yourself right now. And I can tell you that it's not just you. So the data actually is backing this up. I was able to find a 2024 State of Claims report that Experian Health actually publishes each year. And that is really backing up what we are seeing out there. Not only is the healthcare system in the US becoming more expensive, this report did confirm that the US healthcare system is the most expensive in the world and costs continue to rise. And when it comes to denials, providers continue to see claims being denied in greater numbers. And they went on to say in 2022, when they did this survey, 42% of respondents said denials are increasing. And within just 2 years, between 2022 and 2024, the number jumped to 77%, a huge increase. And in that same vein, 67% of respondents said that it's actually also, there has been an increase in the amount of time it takes to actually be reimbursed, from not only from the get-go, but also from appeals from the denials that they're looking at. So to answer that question that I think is kind of on all of our minds, if you're in the denial space, if you're in the revenue cycle space, it's not just you. Payers are just denying more and more. And nearly half of the respondents in this claims report, 46% report that they identified missing or inaccurate information as the primary cause for the denial. And we'll talk about that a little bit as we go through the presentation, but if someone in your organization or a leader in your organization is asking you similar types of questions, like what are other people seeing for denials? Are they seeing more denials, or is it just your coding staff or something like that? I did include this report in the references at the end of the presentation, so feel free to take that and use that if that's something that you're needing for your leadership or for someone at your facility. So what can we do about this? And we'll be talking about this throughout the presentation, but one thing that we are kind of seeing, and I just took a little bit of information from some of our clients and started looking at, are there any trends in the DRGs that we're seeing? And you can see here, the right-hand side where it's green, where it's the 41% majority, are kind of all over the map DRGs. But if you start going to the next biggest piece of the pie, and again, this is just one example, 11% was septicemia, which actually did not surprise me because I know that's been a hot topic lately. And then you see things like endovascular procedures, heart failure, kidneys and UTIs, and then some more broad DRGs like medical back problems. I can kind of understand why that's a denial. So that's kind of what we're seeing, and something like this we're gonna go back to toward the end of the presentation because it's certainly something that you can also do at your facility when you're trending your denials. So first thing we're going to talk about is just what are some common DRG downgrade triggers? What are some top targeted diagnostic categories, just to really get your mind working on what the payers are looking for and what may cause a denial? Because in that way, if you kind of know what's causing it, you can work backwards from there and be able to construct a really solid appeal based on that knowledge. So let's get our brains warmed up a little bit. Some top targeted diagnostic categories, and like I said, sepsis and severe sepsis, like the pie chart I showed just a few slides before, that is definitely a top targeted DRG. And if you think about sepsis, we want to think about the clinical validation thresholds that a lot of our physician advisors and in turn, a lot of our payers use as well. So you start thinking about sepsis criteria, perhaps a payer versus a provider versus maybe what you use as your facility policy could differ. Some facilities use sepsis 2 criteria. Many still use that criteria, and many hospitals have upgraded to the sepsis 3 criteria. There may be some requirements for positive cultures versus clinical indicators. There could be a threshold for documentation of appropriate antibiotic therapy and response. So again, you just kind of want to get your mind thinking about what do payers and physician advisors usually look for in terms of clinical validation thresholds? Some common payer arguments that I've seen is this patient only meets SIRS criteria, not necessarily sepsis. Cultures were negative, and provider documentation is inconsistent across the notes. So let's look at the next one. And again, this is just a way to get your brain thinking in terms of denials. Think, what do payers often look for? What could my documentation be lacking? And that thought process can really help you to later flip that around and develop a really strong DRG appeal. So for example, acute versus chronic respiratory failure, some clinical validations that you would see in your documentation is ABG values with specific thresholds, documentation of increased work of breathing, oxygen requirement specifications, correlation with underlying conditions. Sometimes you'll see conflicting documentation between providers. Sometimes a pulmonologist consult will say one thing and a hospitalist will say another. And especially with respiratory failure, there's a lot in terms of terminology, acute versus acute on chronic, and sometimes that can differ between providers. Some common payer arguments that I've seen, again, the ABG values don't meet the clinical criteria. Documentation suggests hypoxia, maybe a lesser diagnosis than the more severe diagnosis of respiratory failure. Respiratory failure was chronic, not acute. So again, talking terminology. No documentation of intervention beyond baseline oxygen needs, and inconsistent respiratory status documentation between providers. So again, when we're talking about the principal diagnosis and what is driving the DRG, and the first thing you want to do when you're looking at a denial is to kind of think about, okay, what does one normally see in terms of clinical validation? What are some common payer arguments? That kind of thing. So I have two more just to kind of get our brains a little bit warmed up here. Another top targeted diagnostic category that I have seen is malnutrition. And as some of us know, that was on the OIG watch list for a while. So I know a lot of facilities have their own policies and procedures and workflows for validating this diagnosis, but some clinical validation indicators, if you're working appeals and you're working one with malnutrition, you may be thinking of BMI documentation, lab values that really support that malnutrition diagnosis, physical exam findings, documentation of weight loss percentage and perhaps the time frame, and a nutritional intake assessment. So if you're thinking malnutrition, some common payer arguments could be that the BMI does not necessarily support the severity of malnutrition. There's no evidence of dietary intervention beyond routine nutrition services. Patient only supports poor nutritional status and not clinical malnutrition. Physical exam lacks specific findings consistent with malnutrition. Albumin levels may be related to inflammatory processes and not necessarily malnutrition, and no nutritional assessment by a qualified dietitian. And you may be thinking of some others while we're kind of going through this, and that's great. That's the way you want your mind to be working as you're reviewing these. So lastly, again, just to kind of get our mind working in the denial frame of mind, encephalopathy can often be a top targeted diagnostic category as well. For clinical validation indicators, they usually like to see mental status assessment tools utilized, perhaps a baseline cognitive function exam or test, temporal relationship to underlying causes, treatment and resolution documentation, and often a neurology consultation and its findings. Some common pair arguments may be, okay, the altered mental status due to medication effect, not true encephalopathy. There was no formal mental status assessment documented. There was a rapid resolution inconsistent with encephalopathy diagnosis, or encephalopathy appears only in the discharge summary and not supported in the progress notes. So some of those, especially near the end, we'll get to as we get into more of how we craft appeals and how we spot vulnerabilities. But first, let's talk a little bit generally about some red flags. And this is good information to use in reviewing denials and getting your mind into that denial state of mind. But this information could also be used if at your facility you have been tasked with developing prevention tools, or perhaps you're on the CDI team and you want to prevent some of these denials. So it's great general information to have on both sides. So the first grouping for red flags for downgrades of DRGs, if we're specifically talking about DRG downgrades, you've received a denial for respiratory failure and it was downgraded to a lower grade DRG for respiratory illness. The first grouping is going to be documentation inconsistencies. And that would be things like conflicting provider notes. And that could be anything from the hospitalist and the specialist are not agreeing, but it could also be hospitalists from day to day not agreeing or being consistent or being conflicting. The next one would be initial working diagnosis is not confirmed. If that maybe that initial working diagnosis from the H&P isn't really followed through throughout the record and doesn't appear again, something like that. We talked about this with the last DRG grouping. If the diagnosis suddenly appears only on the discharge summary, that can definitely be a red flag if you're not really seeing that story of that diagnosis and how it was developed throughout the stay versus just appearing at the end on the discharge summary. And then if there's any kind of discrepancy in the treatment versus the diagnosis, if there's a feeling there that what was treated doesn't exactly correspond with the diagnosis or the principal diagnosis or the DRG grouping. The next grouping we'll talk about is coding vulnerabilities. And I will caveat this with, that doesn't mean that the coding is incorrect. It could just be that these groupings will possibly be denied more often than other coding scenarios. So it's important to say that, especially with the first one, a single MCC driving significantly higher DRG. That doesn't mean that only having one MCC is incorrect. It just means that there's the possibility that there will be more denials for your inpatient accounts that have a single MCC. Your primary diagnosis selection challenges and complex patients. Perhaps there's a lot of secondary diagnoses that are pretty severe going on at the same time with the patient. Those might be denied more often, and you may have to write in your appeal letter how your coder came about selecting the correct principal diagnosis. It could be a red flag if you have multiple symptom codes with a limited definitive diagnosis. And again, that doesn't mean it's incorrect. Perhaps the providers in that stay did not develop a more definitive diagnosis and there needs to be more study outpatient. But again, that's something that you would have to develop in your appeal. And lastly, perhaps there's a POA indicator discrepancy. Perhaps there's a POA for a diagnosis that rarely happens or something like that. That could definitely be denied more often in those cases. And lastly, some red flags for downgrades. It could be in the length of stay, mismatch or discrepancy area. So for example, if you have a short length of stay with a super complex diagnosis, a lot of payers have that data of the average length of stay for specific DRGs. If there's a mismatch for that, it may be flagged and may be denied. And again, that doesn't mean that it's incorrect, but that may be a red flag where the denials will be a little bit increased for those. There may be a discrepancy in treatment duration versus the condition severity, and an early discharge versus typical clinical course. Again, a lot of the payers have a lot of this information, and they can kind of compare that with what you're submitting and deny accordingly or request more medical records or an appeal. So now that you're equipped with some basic knowledge of DRG groupings that can often be denied and kind of what generally the payers are looking for, and now you're equipped with some common DRG red flags and what might be denied at a higher rate than other patients, let's play a little bit of spot the vulnerability. And what's important with that is when you're reviewing these patients and you're reviewing these denials, one of the first things you really want to do is to take time to review the vulnerabilities first. Just doing that step can really help us craft the most thoughtful response to a DRG appeal. So if I'm looking at this patient, I want to take a brief overview, and of course this is most documentation is going to be a lot longer and more in depth, right, than this simple little snippet here. But you want to take the time just to review the documentation, look at the story, and identify some of the vulnerabilities first and foremost. Then you can work from there. So if we have this case, a 72-year-old female admitted with fever, confusion, and cough, the initial ED note mentions possible pneumonia and to rule out sepsis. Blood cultures were drawn, empiric antibiotics started. Chest X-ray said that infiltrate cannot be ruled out. The provider documentation said day 1, responding to antibiotics, sepsis protocol initiated. Day 2, improved mental status, cultures negative. And the discharge summary said pneumonia with sepsis, acute encephalopathy. Length of stay 3 days. So I want you to take a second and just read this slide and spot what might be some of the vulnerabilities in this case. I'll give you 1 minute. Okay, so let's talk about the first vulnerabilities here. The cultures were negative. That is one of the items that we talked about on the sepsis slide. That may be a vulnerability here. And again, I want to emphasize on the fact that that doesn't mean that the sepsis diagnosis or the coding is incorrect. That just means that this is possibly a vulnerability in the documentation that I need to account for, that when I'm doing my appeal letter, I need to discuss that vulnerability and give supporting documentation or add additional clinical indicators. That is just a stepping stone to be able to construct a very solid appeal. So I have cultures are negative as my first one. My second one I want to talk about is the encephalopathy. And that was one of the red flags that we talked about in the beginning of the presentation, where I said sometimes if we have a diagnosis that just appears in the discharge summary, that can sometimes be a red flag as well. So I'm going to circle that as a vulnerability, and perhaps we need to discuss that in the appeal. Also, the short length of stay doesn't quite match with sepsis. It could be, but it's kind of on the short side of a length of stay. And then it did mention that the sepsis protocol was initiated, but does not discuss afterwards. So I'm going to put that as a borderline vulnerability that perhaps we need to look at later. So how did you all do? Hopefully, as you start to review some more of these cases, you'll be able to spot the vulnerability, and then we'll work from there and be able to craft our appeal letter. So we're going to come back to this case, but first I want to give you a little bit of a structure to be able to form your appeal letters. So the anatomy of a successful appeal is broken down into these categories. First and foremost, you want to have a clear statement of the disputed DRG and/or diagnosis. You would be amazed how many times I see DRG appeal letters that do not have that in there. You want to make sure it's very clear on what you're disputing and the DRG that you would like to see after the appeal. After that, you want to include a timeline of clinical events. This is really where your coding knowledge will come in, where you want to add citations of relevant coding guidelines. You want to evidence any of the clinical indicators and map it to the guidelines, and I'll show you an example of what I mean by that. You want to have provider documentation references. Sorry, 1 second. Sorry about that. Oh my goodness. You want to have your provider documentation references. And then you want to have a clear conclusion with specific request at the end. So when I talk about an introduction, and like I said before, you would be amazed how many times I have seen an appeal letter without an introduction. You want to make sure that it is clear what you are wanting from the payer and the reasoning. So you want to start with a really clear introduction of the patient MRN, the dates of service, the disputed DRG, the denial reason, and anything else you can put in there. For example, a really strong introduction would say something like, our review of the medical record supports the originally signed DRG XXX based on yada, 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 whatever you want to put after that. So always make sure that you start with a really strong introduction. Then you want to move on to your timeline of clinical events. And this is where you really want to tell your story. So you can say something like chronological clinical findings on admission day 1, patient presented with XYZ. By day 2, clinical indicators included XYZ. You can include lab values with reference ranges. You can include radiology findings and dates, times. Go to town on the specifics. You can include provider progress notes, dates, times, quotes, and you can include treatment responses. And again, this is a really great time. If your step one is to review the vulnerabilities, you can walk backwards from there. And here's another example here on the next page where you can be really specific. You can say the specific indicator documented on date XYZ by provider XYZ. You can say things like this lab value on 420 was out of range and the reference range is typically this to this. So you can be as specific as you need to be, or you want to be, or you can be in these appeal letters. And again, you can include treatment provided, the specific treatment, and when it was initiated. And you can talk about the clinical response. The next aspect of crafting a really solid appeal letter is using your coding references. You can include citations of relevant coding guidelines. You can include clinical evidence mapped to your guidelines. So when we talk about guidelines, we can use our ICD-10 official guidelines. We can use our index references. I have done a lot of appeal letters where I cite the index specifically, or even the tabular, where I say the tabular says that this includes XYZ. You can also talk about the specific coding clinic guidance. And don't forget about your medical society clinical criteria. Our medical societies are a wealth of information, and they have things from clinical indicators to coding, which are great to reference as well. Or facility-specific clinical criteria is great as well. If you remember back to the beginning of the presentation, when we were talking about sepsis, that's a great one to use facility-specific clinical criteria for. You can talk about which sepsis criteria you utilize at your facility and which physician advisor, what your workflow is, how that works, is CDI involved. You can talk about all of that in your appeal letters. Same thing for malnutrition. A lot of facilities have something in line for malnutrition, how that has worked, when it is coded, when it's not coded. So use all of that within your appeals. And you can really, like I said, go to town, be specific with your coding guidelines. You can quote coding clinic and include the quarter and the year and the page. And you can say, when documented by the provider, this condition can be coded due to coding clinic. You can really use your specifics and show your knowledge in some of these appeals. And lastly, the last two components are a little more self-explanatory. So just to wrap up the essential components area of how you craft an appeal letter, you want to have provider documentation references. So what does that mean? You can use anything within the record, any quote. You can say, this progress note on day 1 said this. So that means it was a working diagnosis throughout the entire stay. You can really go to town on being specific in your provider documentation as well. And just like I said, don't forget a conclusion. Don't forget your introduction, and don't forget a conclusion. Really talk about what specific request you are asking for from the payer and what you expect. So as we move on to mastering DRG appeals and putting all of this information together, let's just look at a basic sample case. So let's say you receive a sepsis case, because that's what we had been talking about in the beginning, and this was downgraded to respiratory infection. you're going to review the case and say, okay, these vulnerabilities are here. How can I present this? And then you craft your appeal letter kind of in this manner. So you'll start with the initial DRG that was submitted, which was 871, and then you'll put what it was downgraded to. And you will include appeal elements like the clinical timeline. You'll put in the ED presentation was this, and you'll include the vitals. It's even great if you add in who the provider was, what time it was. The more specifics, the better. You'll include that blood cultures were drawn and broad spectrum antibiotics were started. You'll include that intubation for respiratory failure occurred and that the blood culture was positive at 48 hours. The guidelines for sepsis, again, you can include that my facility uses sepsis 3 criteria, and here in the documentation is where it's notated. You can include your ICD-10 official guidelines regarding POA. You can include coding clinic guidance on respiratory failure, and you can include things like clinical evidence, like the SOFA score and how it was calculated, and you can talk about which providers calculated that score. You can talk about the treatment, things like antibiotic response and ventilator duration records. And you want to have a very solid conclusion, like I talked about already. So you may be thinking, okay, that's great and all, but what if I have documentation issues? You haven't talked about that yet. What if I have all of these vulnerabilities and I'm not sure how to approach a denial? Or should I just not appeal them at all? I get that question all the time. And what I say to that is, you always want to identify the vulnerabilities, but you can always tell a story with these vulnerabilities. So for example, Vanessa, I have these documentation mismatches. One provider citing one thing, another provider stating another. Is this unappealable, for lack of a better word? Not always. In your appeal, you can address contradictions directly and you can explain it. I'm sure if we have any clinicians in this webinar, they would say that clinical presentation and admissions and hospital durations aren't always a straight line. Patients can fluctuate, working diagnoses can change and evolve throughout a stay. So you can address that contradiction directly and say, yes, it does conflict because provider A saw the patient in the morning and they did not decline until provider B saw them in the evening, and the cultures were not positive until XYZ. You can really tell the story. So same thing with something like missing key timestamps. Tell the story. If it's unclear when the conditions developed, if you're able to review the documentation and piece together when the timeline of a clinical progression occurred, do it. It's not always unappealable, right? What about something like weak clinical evidence? Perhaps there's one single clinical indicator or one calculation that the payer received that they're basing their DRG downgrade off of. Well, build a comprehensive clinical picture with supporting elements if it's available. Again, this may not always be possible, but sometimes it is possible based on your findings and review. So let's go back in our brains to the vulnerability case. What story can we tell here? So if you remember, we identified some of the vulnerabilities. We identified that the cultures were negative. We identified that pneumonia with sepsis was on the discharge summary, and that was something that was worked throughout the entire stay, but the acute encephalopathy did not appear in a lot of the documentation. And the length of stay was a little bit short. And we also talked about how the sepsis protocol documentation was a little bit lacking. So let's talk about this case. How would we appeal it? Well, we can talk about the vulnerabilities directly, and we can discuss those concerns, and we can identify additional items to support that. So again, we would always want to clearly identify the disputed DRG. We could document any clinical indicators that we find that support sepsis. We could address perhaps these common payer arguments or the vulnerabilities we've already identified. We could document sepsis criteria despite the negative cultures, and we could really utilize our facility policy on how that is calculated or what criteria is used to diagnose sepsis. We could add additional information about how the appropriate treatment protocol was initiated. We could add additional provider documentation that shows consistency. And we could find where the documentation possibly states why the length of stay was a little bit on the shorter side. We could also, if you look on the right-hand side, we could add in some great official coding guidelines. We could talk about the combination of SIRS criteria with a suspected source of infection meets clinical criteria. And then we'll get into our coding clinics. There's a great coding clinic on fourth quarter of 2016 that if the documentation is unclear as to whether the patient has sepsis, we are to query the provider. And in this case, the provider documentation clearly indicates sepsis throughout the record, and we could include that in our appeal of where all of that is located. And also per coding clinic first quarter 2019 on pages 17 through 18. And again, if you notice, very specific, negative cultures do not preclude a diagnosis of sepsis. So you can include that in your appeal as well. So again, just because your case has vulnerabilities doesn't mean that you can't appeal it. And in fact, like I talked about in the beginning of the presentation, spotting the vulnerabilities first often helps us to create a really solid appeal. So just a few last things to wrap this up in terms of any good tips and tricks that you could offer me. I'm new at this. I would love to really dig into this at my facility, or perhaps you're on the CDI side and would love how we close the loop on some of these things. The first thing I do want to talk about, because we haven't touched upon it yet, is coding validation. This really goes with that being said, but please verify the coding before you start appealing these. I often recommend a second level coding review before preparing the appeals, because we don't really want to appeal anything that is incorrect. We want to verify that all the coding guidelines were appropriately followed, and we definitely don't want to defend what I call indefensible coding. So that goes without being said, but we definitely need to have that step in place at all of our facilities to ensure that we're not appealing something that isn't correct. We also want to check for things like proper POA indicator, especially for those conditions that, like we talked about in the beginning, like sepsis and respiratory failure. We also want to confirm that the ms-drg assignment follows the encoder, grouper rules, and anything else you have set at your facility. So going back to this slide, and this again is just a client example, a quick example of what their trending was looking like for DRG downgrades. This is something you can easily do at your own facility. You can take the data of your denials and turn it around to really enhance your process. You can track denials by payer, and you can identify pattern-based targeting. Perhaps one payer is really targeting a certain DRG. You can really dig into that and find what the reason is. You can build payer-specific appeal templates that address their common arguments. And I know a lot of us in the recent years, a big goal that a lot of the facilities have is how much can we automate to really use our resources to the best of our ability. So if you can automate certain things, then you have more resources to review the things that you can't automate. So is there some automation that we can put into place in terms of templates for certain payer arguments? You can create a citation library of relevant coding clinics. You can even divide it by diagnosis so it's searchable. And you can use a physician advisor for complex clinical validation of appeals, which is always a great tool to have in your arsenal. Some practical workflow improvements, like I said, you may be on the provider education side, you may be on the CDI side, or you may be in the revenue cycle side where you're working on these workflows. So some improvements that we recommend is to implement a pre-bill clinical validation for high-risk DRGs or perhaps high-risk diagnoses. I know some facilities have put in place pre-bill clinical validation reviews that coincide not only with their denials, but perhaps OIG watch lists. So watch out for that. And of course, like I explained on the past slide, sometimes it has to coincide with your resources and how many resources you have dedicated to that. So if you really need to focus on the uncertain DRGs, that's certainly a great strategy. You could create a 48-hour review process for cases with single MCCs. And like I said previously, a single MCC isn't necessarily incorrect, but because it's a red flag, that may be a process that you would like to incorporate. You can develop standardized provider query templates. I know that's been big at a lot of the facilities that we work with lately. You can use a dedicated denial prevention specialist, and you can create a formal when to appeal policy. That's always a great idea with clear criteria for pursuing appeals and which ones are more appropriate for write-off. I would be remiss without talking about clinical validation and the roles of a coder versus a provider versus perhaps a CDI specialist that's also a clinician. Coding Clinic does say that clinical validation involves a clinical review of a case to see whether or not the patient truly possesses the condition that was documented in the medical record. That really needs to be performed by a clinician, an RN, an MD, a therapist. Clinical validation is beyond the scope of DRG coding validation and the skills of a certified coder. So I just wanted to clarify that in all of this because sometimes appeals require that we input clinical indicators within our appeal. So you really have to develop a policy at your facility where the line of the coder is versus a physician advisor versus a CDI specialist versus a denial specialist. Are they certified as a clinician or a coder? And a way that a lot of our clients and even facilities I've spoken to throughout the country have developed their policy is that you can develop a policy that says, if you see XYZ, hold it for review. If you see XYZ, query the provider. So in that way, the coding role is staying within their role, and the clinician is staying within their zone as well. So that's what the Coding Clinic fourth quarter 2017 says. Facilities may review documentation to clinically validate diagnosis and develop policies for querying the provider for clarification to confirm a diagnosis. So for example, if you're talking about malnutrition, some facilities have developed a policy where if they are seeing certain criteria in the documentation, they always hold it for physician advisor clinical review prior to coding it. That's a great example of clinicians and coders working together while still maintaining what their role is and not stepping across that. So I did want to really emphasize that at the end of this presentation and make sure that was clear, that coders still cannot go beyond their role too much in these appeals, that they can definitely include the clinical indicators. We know a lot as coders, but we can't go beyond that. If it does require something beyond that, it would be great to develop a team that maybe had both professionals there, or a team that could work together. So just something to think about. Lastly, just to wrap up the last few tips and tricks, closing the feedback loop is always important. You want to track appeal outcomes by code or provider, service line. You can share downgrade patterns with CDI and physician teams to improve that documentation. If you see vulnerabilities, let's get that fixed. Let's get that template updated. You can develop targeted education based on trends and denials. If you're getting a denial where you're seeing the coding is incorrect, get that education back out to the team. Don't forget to close that feedback loop. And lastly, you can establish guidelines for when to seek, again, physician advisor input before appealing. Lastly, recovery optimization. Like I said, sometimes at the facilities, it's a little bit of a chess game about your resources. You can calculate your appeal success rate by diagnosis and focus your efforts accordingly if resources is an issue. You can track financial impact of each downgrade category. You can set benchmark goals for appeal success rates, and you can even look at that by DRG. And you can implement a rapid response team approach for high dollar accounts. So just to wrap up, I did create a little cheat sheet of a DRG appeal letter structure and how that would look for you. So you would have your clear statement in the beginning, a timeline, coding guidelines, clinical evidence, any documentation, be specific, and a conclusion. And lastly, I have the references. The state of claims report that I talked about in the beginning is there, as well as some great information from ACTIS. And just a couple examples, there are the sepsis resources on sepsis, as well as malnutrition. But there's a lot of great information on the ACTIS website as well.